Podcast. I'm Francis Deng, a neuroradiologist at Johns Hopkins and your new podcast editor for the American Journal of Neuroradiology. It's a pleasure to be with you. Today, we'll be discussing an insightful article from the August 2025 issue of AJNR titled Frontal Paraventricular Cysts, Refined Definitions and Outcomes. This work is by Dr. Matthew Whitehead and colleagues from the Children's Hospital of Philadelphia. This study addresses a frequent and sometimes challenging diagnostic dilemma when reading pediatric neuroimaging. Frontal paraventricular cystic changes are not uncommon, with a reported postnatal prevalence of about 6%. However, the term periventricular cyst is often used nonspecifically and can encompass a wide range of pathologies, from benign developmental variations to markers of significant underlying brain injury. And so the differential diagnosis of this includes conatal cysts, subependymal pseudocysts, areas of necrosis, and enlarged perivascular spaces. Distinguishing these entities is critical as their associated prognoses can vary significantly. And this study aimed to refine the neuroimaging definitions of these frontal horn cysts and correlate them with clinical outcomes. The authors conducted a cross-sectional study retrospectively reviewing their institution's neuroimaging database from 2006 to 2023. They searched for radiology reports containing the terms frontal horn cysts, periventricular cysts, or conatal cysts in both pre- and postnatal brain imaging studies. They analyzed 205 brain imaging examinations from 110 distinct subjects, and this included mostly MRIs, 148 of them, as well as some ultrasounds and CTs. The patient cohort was composed of 5 fetal cases and mostly postnatal cases ranging from birth to 19 years of age. So a key finding from this study was the high rate of initial misinterpretation. A striking 35% of examinations initially diagnosed as conatal cysts were, upon further review, found to represent other entities. The most common misdiagnoses were necrosis, found in 23 cases, and enlarged perivascular spaces, seen in 20 cases. Other misinterpretations included caudothalamic groove, germinal-lytic cysts, septations, adhesions, ventricular asymmetries, or even a blood vessel coursing through the ventricle. This underscores the clinical challenge these findings present. And so this study systematically categorized frontal paraventricular abnormalities based on the consensus of the reading radiologists, based on their imaging characteristics, location, size, shape, and signal intensity, and so forth, to improve diagnostic specificity. They also grouped conatal cysts and frontal subependymal pseudocysts together under the umbrella term frontal horn cystic lesions, or FHCLs, as they're not reliably distinguished by imaging alone. So this is their classification system that includes FHCLs, or frontal horn cystic lesions, necrosis, enlarged perivascular spaces, caudothalamic groove periventricular pseudocysts, frontal horn asymmetries, intraventricular septations, and ependymal vessels. So let's start with frontal horn cystic lesions, or FHCLs. So as demonstrated in this figure, for those of you who see the video version of the podcast, FHCLs are typically ovoid, elliptical. They extend parallel to the long axis of the ventricle. They're characteristically located at the junction of the frontal horn base and the lateral ventricular body. And a key feature is that they abut and appear to fill into the lateral aspect of the frontal horn margin, almost like a puzzle piece, with no significant tissue separating the cyst from the ventricle itself. On MRI, if obtained, they follow CSF signal completely in all sequences and are generally simple without surrounding gliosis or volume loss. Now let's consider white matter necrosis and a associated finding of a caudothalamic subependymal pseudocyst, both shown in figure 2 here. So first, white matter necrosis presents differently from FHCLs. These lesions are centered in the white matter itself, separated from the ventricular margin by intervening tissue, such as an ependymal vein on this image, which appears echogenic on ultrasound or as a flow void on T2-weighted MRI. And as you can see in this figure, they're often located more superiorly and more laterally compared to frontal horn cystic lesions. Necrotic cysts can be more irregular in shape, variable in size, are often associated with ventral white matter volume loss and ex-vacuo dilation of the adjacent ventricle. So while they can mimic frontal horn cystic lesions, especially on ultrasound, the presence of associated volume loss on follow-up is a key distinguishing imaging feature. Also on this figure is another important entity, which is the caudothalamic groove subependymal pseudocyst. These are also called post-hemorrhagic pseudocysts or germinal-lytic cysts. These are indicated by their specific location in the subependymal region of the caudothalamic groove, but because they're close to the frontal horn, they can be erroneously called frontal horn cysts as well. They bulge into the ventricle and will not expand into the adjacent white matter, distinguishing them from the frontal horn cystic lesions. And the study notes that in utero CMV infection is an association with having multiple bilateral caudothalamic subependymal pseudocysts. And then finally, we have enlarged perivascular spaces, or PVS. So enlarged perivascular spaces are another common mimic of frontal horn cystic lesions. This figure shows a typical example. And compared to frontal horn cystic lesions, enlarged perivascular spaces are generally smaller, rounder. They're often located just lateral to the tip of the frontal horn, deep to an intact ependymal lining. A very helpful diagnostic clue on MRI, if you're so lucky to see it, is the visualization of a central dot-like hypointensity on T2 weighted image or tubular structure in a different plane that can represent a normal vessel that is traversing this space that confirms that this is a perivascular space. Enlarged perivascular spaces typically remain stable over time, but can occasionally enlarge. So this study also investigated clinical correlation. I'm showing you part of one table here. When they analyzed associated clinical conditions, the researchers found significant differences. Congenital heart disease and gastrointestinal disorders were significantly more common in subjects with frontal horn cystic lesions, necrosis, and caudothalamic groove subependymal pseudocysts compared to those with enlarged perivascular spaces. This suggests that the enlarged perivascular space is a benign entity, while the others should be regarded with some degree of clinical suspicion. This challenges the long-held belief that isolated frontal horn cystic lesions are simply benign and suggests that they may exist on a spectrum of injury. The authors acknowledged some limitations to their study, including the retrospective design, the potential for ascertainment bias, as these were identified based on searching radiology reports. However, they believe that their cohort is representative of what radiologists may encounter in daily clinical practice. So in conclusion, this study from Whitehead and colleagues provides clinically relevant insights. It highlights that over a third of cases reported as conatal cysts are actually other entities, most notably white matter necrosis or enlarged perivascular spaces. And a key takeaway for practicing radiologists is that careful attention to these imaging features can differentiate these entities. Again, frontal horn cystic lesions is an umbrella term that subsumes conatal cysts and frontal subependymal pseudocysts. These are ovoid and fit into the lateral ventricle margin. Necrosis is more variable in size, often larger, located superlateral to the ventricle, and can be associated with white matter volume loss over time, which confirms that diagnosis. And finally, enlarged perivascular spaces are small, round, and may contain a visible vessel. So there you have it. This refined approach to what may seem like a simple frontal horn cyst can provide some critical prognostic information and guide further clinical investigation. That's all for this AJNR podcast. Thank you for joining me. I encourage you to read the full article, Frontal Paraventricular Cysts, Refined Definitions and Outcomes by Whitehead and colleagues in the August 2025 issue of AJNR. Until next time, I'm Francis Deng.